The critical factors in labor are the 4 P's of labor. And this is the person, passage, passenger, and the powers. So we're going to discuss that. The passage. It's the size of the pelvis, or the type of pelvis, and the ability of the cervix to dilate and efface. So as you can see, there's 4 pelvic types. There's the gynecoid type, the android type, the arthropoid type, and the platypoid type. So you can kind of see which would be best to actually deliver a round baby head. So your gynecoid type is your best. The anthropoid type is okay too. The android and the platypoid, a little more difficult. Your doctor would discuss this with you. This isn't anything that you would know automatically. I do have people ask me questions about that. How do I know what type of pelvis that I have? Well, your doctor has already decided that. Now, if he has discussed with you, especially if this is your first baby, and he has discussed with you, or she has discussed with you, that a C-section would probably be best for you because of your type of pelvis, this would be why. Okay? Now let's talk about station. You'll hear the physician or your nurse discussing station. So 0 station is at what we call the iliac crest, or the ischial spines. The ischial spines. So that is at a 0 station, and that's when we say the baby is engaged. And engaged means it's not floating around. We can't move it. When we do a vag exam, baby's head is down and it's staying down. The negative numbers means that baby is higher up in the pelvis, and it'll get to the point where it's still floating. So if baby's still floating, that means it's not engaged. And of course, a +5, as you can see in this image, would be like the baby crowning. You could actually see the top of the baby's head. The passenger. The passenger is the fetus itself. So the fetal head, you'll notice the size, the presence of molding, because babies have suture lines, and basically their skull is not one hard skull, as you probably know. It is separated into different bones, and they have what are called suture lines and fontanelles, where there's no bone. This allows for baby to pass through the pelvis by molding its head. So the head, the bones can actually overlap. They can kind of stretch or mold themselves to fit through the pelvis. So that's why some babies look like they have a so-called cone head. Fetal presentation. Cephalic, which is head down. Breech, which could be feet, or it could be butt or shoulder. Fetal position. So baby, like I said, could be, head down, which is called vertex, or could be transverse, which is sideways. And also engagement. That's the largest diameter of the presenting part where reaches or passes through the pelvic inlet. And we're hoping that is the head for having a vaginal delivery. Now this is what's called an anterior presentation. And this is called a posterior presentation. This is a frank breech, where you can see the baby's butt is down. Now the powers. The primary power is the uterine muscle contracting, and the secondary power is mom's actual pushing efforts. The primary power were the uterine contractions. They're rhythmical and they're intermittent, meaning there's some pauses in between. because we can't have full-on contractions where there's no let up in between or no relaxation, because that, of course, would wear out mom, and it also wears out baby. Contractions themselves are involuntary. You cannot control your contractions. They have 3 phases. Please don't spend a lot of time learning these phases because it's very simple. The contraction starts, that's your increment where it's building up. That's your longest phase. There's the acme, which is the peak of the contraction, and that's the strongest phase of the contraction. And then the decrement, which is the letting up. So it starts, it peaks, it goes down. Okay? Contractions are measured by palpation. So either the nurse is laying her hands on your abdomen to feel the strength of the contraction from beginning to end. Or we'll use, which if you're going to be in the hospital, we are going to have a external I cannot pronounce this word, tocodynometer. We usually just call it a toco. So what it does is it actually measures the pressure of the uterine contraction onto the monitor itself. There's a little flat button. So as the uterus contracts and hardens, it pushes on that button, and that's what makes the picture that you'll see on the monitor. And I have a fetal strip on here for you to see. And there's also an intrauterine pressure catheter. That is a catheter that the doctor would insert through the vagina, through the cervix, and it measures the pressure inside of your uterus. Not every physician uses that since it is invasive, but there is a possibility that you might have one. Here's a picture of contractions. You see on the bottom with the green arrows, those are the contractions. The squiggly line above it is fetal heart rate. So how your contractions are measured is by the frequency, which is how often they are, how often they're coming. And you can count that either from the beginning of one contraction to the beginning of the next contraction. And also the duration, how long the contraction actually lasts. And that's from beginning to end. And then, of course, intensity. That's the strength of the contraction during the acme or during the peak. Now, we can feel from palpation how strong the contraction itself is, or from our monitor. And sometimes, if mom is really, really skinny, really, really thin, there isn't much of a fat layer on her abdomen, the contractions are going to look huge on the monitor. If mom's a little fluffier, like I was when I was pregnant, they're not going to look as pretty and tall. But the most important part here is we're measuring the contractions. We can feel through palpation how strong they are. But to get an actual pressure reading, an accurate pressure reading, you would need that internal catheter. But like I said, it's not always necessary to have that. Secondary powers. Use of abdominal muscles and pushing during the second stage of labor. And then the person. Coping mechanisms. Now, that's influenced by your perception or experiences. So positive versus negative. It is important to be informed, and of course you want to be informed because you're watching this PowerPoint, and gathering as much information as you can. However, there are people who are going to tell you every worst scenario that could possibly happen, and we all know that one person that if anything was going to go wrong, it was going to go wrong to them, and they're just going to scare you to death. Well, I'm going to tell you, don't listen to those people. But like I said, be informed. Just know what to expect. Your anxiety will go down if you do have sort of a perception of what you might experience. And then having a good support system. So role of the father, family, significant others, can actually directly influence your perception of your childbirth experience. Preparation for childbirth. preparation during pregnancy, maternal awareness, like I said, some self-education, and then having a sense of control of your childbearing experience. Now let's talk about some warning signs of labor. Lightning. Lightning is when the baby drops. And all of a sudden you might realize you wake up one morning and go, oh, I can breathe better today. Well, that's because baby's now down in your pelvis and not trying to be all up in your rib cage so you can't breathe. So that's what lightning is when baby drops. Braxton Hicks contractions. Now those are practice contractions. They might be a little uncomfortable, but mostly what you're feeling is tightening. They shouldn't be painful, okay? If you're having painful contractions, then you're probably having actual contractions. Now, the reason we'll know if you are in true labor is having changes in your cervix. So having a vaginal exam is important. That's how we know if you're in actual labor, because of the ripening of the cervix. Having bloody show is another warning sign. As your cervix changes, shortens or dilates, you'll have some bloody show. The cervix is very, very vascular. So any changes in your cervix will cause some bleeding. Just the same as when you had a vag exam at the doctor's office and you had a little spotting when you got home. Same exact thing. Anything that touches your cervix or you're having cervical change, you're going to have some bloody show. Rupture membranes. So if your water has broken, you're having leaking, or you had a big gush, that's definitely you're in labor. And then even having that sudden burst of energy, like that nesting instinct, like, oh my gosh, I got to get everything ready. I've got to get all the clothes washed. I've got to get diapers ready. I got to pack my bag. That could also be a sign that labor is impending. Now let's discuss signs of labor and the differences between true labor and false labor. Now this would be if you're at term, okay? So if you're having contractions that are irregular at first, they become stronger, longer, closer together, that could be a sign of true labor. If they're irregular, they're short, they're not getting closer or stronger, it could be false labor. In true labor, if you walk around, it's going to make your contractions stronger. But if you walk and the intensity goes down or the contractions decrease, it's considered false labor. If laying down doesn't make anything go away, then it could be true labor, whereas laying down and resting does make false labor go away. Contractions felt in the lower back, true contractions felt in the lower back, and they radiate towards the front into the groin area. Okay, so that's your true labor contractions. And you might even feel them like down in your thighs, like that deep ache down in your thighs. Contractions that are only felt in the top of the uterus, like that tightening, is not true labor. And in true labor, your cervix, of course, softens, it thins, it opens, you'll have bloody show, and then, of course, the fetus is beginning to descend, which is why you're having the cervical changes. In false labor, your cervix might soften some because your body's practicing with those contractions, but there's not really going to be any cervical change or thinning going on. And then, of course, baby's position is not going to be changed as well because it's not going to be, engaged or more descended into the pelvis. Now, before you go to the hospital, like if you decide, okay, I think I'm going to be in labor, I'm going to go to the hospital, okay? Try these things. Drink plenty of water. Lie down on your left side. Take a bath. But, of course, if you think you're leaking, don't take a bath. Just come on in and be checked. Count your contractions from the beginning of one to the beginning of the next, and also count how long those contractions are lasting. if they go on for every 3 to 5 minutes after 2 hours, then go to the hospital. Okay? Now, if you get to the point where you're contracting often, even if it's every 6 minutes, but they're painful, you can't talk through them, you can't walk through them, come on into the hospital. It doesn't hurt to be checked, and that is the only way we're going to know if you're in labor. Okay? How to time your contractions. Like I said, from the beginning of one contraction to the beginning of the next one. Okay? And then counting the duration, of course, is going to be from the beginning of the contraction to the end of the contraction. So they should be a minute long or a little bit longer. If they're 40 seconds or less, well, less than 40 seconds, like say they're only lasting a half a minute, then it's really not a true contraction. Okay, so they need to last about a minute each. Okay, so what do we need to bring to the hospital? You need your insurance card and you need your driver's license. We'll need that information for you to check in. Also, your prenatal record. Like I said, sometimes they don't make it from the doctor's office, to the hospital. It's a rare occasion, but it does happen. If you can get a copy of your prenatal record on your last visit, that's great. If not, and you just happen to know your beta strep is positive, make sure you tell your nurses that, okay? If you have a birth plan, that's okay too. It helps, like I said, it decreases your anxiety, so you have a little bit of control over what's happening, but it needs to be approved by your doctor. Especially, occasionally we'll get things like, I don't want an IV, I don't want to be on the monitor, I want to be able to walk around, and those things are okay. However, I do recommend, you might not need IV fluid, but you do need to have an IV access. That is any type of an emergency situation, we need to have an IV access. And that's coming from being a nurse. If you need medication, or if, say, you started bleeding heavily, we need to have that IV access so we can get appropriate medications and drugs to you. Okay? So just be realistic with your birth plan. Okay? All right. Also, a car seat. Make sure you have your car seat in the car. Okay? It needs to be secured in the car. You can also go by Troop L. And also you can talk to someone at the parenting center. I think they're certified there. But definitely at Troop L, they can do a car seat check to make sure that it's secured into your vehicle. We can't let the baby go unless the car seat is in the car and secured. We as staff at the hospital cannot help you put your car seat in the car. Okay? So keep that in mind. Some infant clothes and supplies. Now, I list supplies on here, but that does not mean you have to bring your own diapers, bottles, anything like that. Just whatever you would want, your baby to have. Okay? Comfortable clothes. Very, very important. If you want to bring your own pajamas to wear after delivery, that is perfectly fine. Anything that you don't mind getting blood on, because that does happen, as long as that's okay with you, that's cool too. Some ladies will like to bring their own hospital gown. That is all right. However, it needs to be a gown that can be opened from the back. Okay? Especially if you plan on having like an epidural, or also in an emergency situation, we need access to your back for anesthesia purposes. So just remember, it needs to be some type of hospital gown. Toiletries. Anything you need is, shower things like your own toothpaste, your own toothbrush. If you like your certain shampoo, whatever you need to bring. We do have basic necessities here, but we're not going to have anything fancy. Your support person, very important. Now, especially now during, post-COVID, we're only allowing one support person with you during your labor and delivery. We're not allowing other visitors into the hospital at this time. That could change, in the near future, but as of now, it's just one. And then relaxation and distraction items. If you need something to play relaxation music, that's okay to bring. You can't have candles in the hospital because we can't have anything burning. Other little scented items are okay as long as they're not so perfumed that they leave the room. And we also don't want a lot of perfumey kind of items around baby as well. Okay? But if you have questions about any of those things, like I said, feel free to email me. A labor check. So say you come into the hospital and you think you're in labor. Okay, so what's going to happen? The nurse is going to bring you to the back into the triage area. She's going to put you on the monitor to monitor contractions and monitor baby's heart rate. You will have a vaginal exam or a cervix check. You might be asked to walk to see if your labor does progress and to see if your cervix changes. We have on here, don't get frustrated, upset, or mad if you're sent home. As I mentioned before, the key to really knowing if you're in active labor is cervical change. So if your cervix is not changing, it could just be early labor. The bad thing about early labor is it could last for days. Occasionally you'll hear ladies saying, I was in labor for 72 hours. Well, it's a possibility. Early labor, however, can be uncomfortable, but you're not going to feel like you're dying. Because early labor, it's just a progression. Your body's just working its way up. However, if it gets to where it's so uncomfortable, like you said, you can't talk through it. You can't, walk through it, and you're that uncomfortable, please come back to the hospital and we will take care of you. Now, when you're admitted to the hospital, your assessment is going to be done by your nurse, including your cervical exam. We'll obtain a complete medical history from you. So we need basic medical history information as well as surgical history information. And then mom's family members. We don't need any information from dad. We do need moms about siblings, parents, grandparents. We'll obtain consents for delivery, for blood transfusion. Not that blood transfusions are common, but in an emergency situation we would need that consent. And also a consent for anesthesia. Now, just because you consent for anesthesia doesn't mean that you have to have an epidural. It just means that in an emergency situation, if we had to do, say, an emergency C-section, we have consents for your blood and for anesthesia. Any questions regarding your pregnancy, we'll review with you, discuss anything about your current medications, if you have a birth plan, whether or not it was okayed with your physician, and then what the plan is as far as what your physician ordered. And then, of course, who your pediatrician will be and the type of feeding method that you plan on having for your baby. You'll have an IV started, and fluids will be infused, and that's just to make sure you are well hydrated. Your blood work will be drawn, and that's CBC, the RPR, as well as your blood type and RH. If you are beta strep positive, you will be started on antibiotics. So like I said, we need to know that if you are positive so we can get those antibiotics going. We talked about the visitor policy because right now it has changed, post-COVID, of only having one support person. And then as far as what you can eat during labor, ice chips and hard candy only. Now here's a video I'd like to share with you. Since I'm doing this voiceover, I can't play the actual video, but if you could pause it, write down that link so you could watch it. This is a very good video that explains dilation.